Respected senior physicians, dear friends and colleagues, good evening and very warm welcome to the API meet for the month of February this year. Of course, before I start, there has been a sad event. We are all saddened by the sudden unexpected demise of a dear colleague of ours, Dr. Thomas Paul, a fine gentleman and a thorough physician. In his memory, let us all rise and pray for a minute for the departed soul. And now for today's meet, we had two sessions. First is a didactic talk on comprehensive management of atrial fibrillation. The talk will be delivered by Dr. Praveen Sreekumar, who is a consultant in interventional cardiology and electrophysiology at Aster Medicity. The session will be chaired by Dr. Sujith Vasudevan. Second topic is a clinical case presentation from Rajagiri Hospital. Now for the first talk, may I invite the chairperson, Dr. Sujith Vasudevan, to the dais, please. Dr. Sujith Vasudevan is a senior consultant in medicine, and he is well known to all of us. He has got wide experience spanning several decades in various branches of internal medicine. Now I'll request Dr. Vasudevan to kindly introduce the speaker.
Chairperson Dr. Radhakrishnan, Speaker Dr. Praveen Sreekumar, and fellow members of API Cochin chapter. I am privileged to be here this evening to introduce the speaker, Dr. Praveen Sreekumar. The topic of atrial fibrillation is something which is very old. I remember nearly 50 years ago in medical college, we were taught that atrial fibrillation was the commonest type of dysrhythmia or arrhythmia of the heart. Common conditions which, the commonest condition, or probably the only condition that we were taught which gives rise to atrial fibrillation was valvular heart disease due to rheumatic fever. The tools in our armamentarium were very minimal. Clinical examination, an ECG and a chest X-ray. There were no echoes, no CTs, no MRIs. Treatment consisted of trying to lower the heart rate by giving digoxin, giving diuretics, and giving whatever anticoagulants were available at that point in time to try and prevent or minimize embolic phenomenon. There has been a sea change since then, though the condition is basically the same. The number of causes we know which lead to atrial fibrillation have increased. Our understanding of the pathophysiology and especially the various modalities, both drug and non-drug, to treat atrial fibrillation or manage atrial fibrillation have increased manifold. To discuss these, especially the management of atrial fibrillation, we are privileged to have Dr. Praveen Sreekumar, who is a well-known consultant interventional cardiologist and cardiac electrophysiologist from the Center of Excellence in Cardiology at Aster Medicity. Dr. Praveen had his MBBS from the Government Medical College, Trichure, and his MD in General Medicine from the Government Medical College in Calicut. He then joined the Jayadeva Institute of Cardiology in Bangalore, where he obtained his doctorate in medicine, DM, in cardiology. Being interested at that point in time, he further pursued a fellowship in cardiac electrophysiology from the same institute, the Jayadeva Institute. In addition to the DM and the fellowship in electrophysiology, he also is a member of the Royal College of Physicians and has been honored with a fellowship of the Royal College of Physicians. He has vast experience in several centers. He has worked briefly in St. John's Medical College, Bangalore. He was the electrophysiologist in Jayadeva in Bangalore. He has worked at the Trichur Heart Hospital, Trichur, and the KIMS Hospital in Trivandrum before joining Aster Medicity as a consultant cardiologist. His interests are complex angioplasties, adult cardiac electrophysiology, including 3D mapping and radio frequency ablation, and pediatric electrophysiology. It is his desire to set up a regional center for pediatric electrophysiology, and I'm sure that he's well on his way to doing it. Recently, Aster Medicity has started the Aster Heart Rhythm Center after the obtained facilities for doing cryoablation for atrial fibrillation. And Dr. Praveen has been honored by being appointed the director of the center. It's my pleasure to introduce Dr. Praveen and to welcome him for this evening's program. I now request him to deliver his lecture.
Thank you, sir. That was too comprehensive an introduction. I did not expect so detailed. So anyway, I'll just go skim through the newer therapeutic options in atrial fibrillation. How do we see atrial fibrillation in the present times? As sir told, it's not a new disease. It's a very old, as we know from time memorial, from our MBBS days, we know what is AF. And as sir told, it's the most common atrial arrhythmia. And the ECG characteristics are quite known: narrow QRS, irregular rhythm, and absent P waves. That's the ECG characteristic of atrial fibrillation. Clinically equivalent is a pulse apical deficit and irregular pulse with a pulse apex deficit. That will be the clinical definition. And from that we have progressed on to multiple different types of AFs which will come to. And also the problems are that it may produce fast ventricular rates and it may produce stroke. In nutshell, these are two clinical problems of atrial fibrillation. But slow ventricular response in an AF may indicate some underlying sinus node or a AV node disease. So that we should keep in mind. And sometimes this is a typical AF, no P waves. When you see an ECG with no P waves, first thing comes to mind is AF. Sometimes the irregularity is very subtle. In this ECG, it might look regular at the first shot, but if you see carefully, it's irregular. And this is a fast ventricular rate ECG. And you may have to differentiate it from a VT if it's a broad QRS. And you should be more careful when it is very regular. Like in this case, it might be a underlying complete heart block. In general, in elderly, as age goes on, the ventricular rates slows down because there is underlying AV node or a sinus node disease. So AF with a slower ventricular rate, the patient is in a more advanced electrical disease. So it's not only atrial arrhythmia, the fast arrhythmia, which is a problem. When there is slow ventricular rates, you need to think of that the underlying conduction system tissue is also not very normal. So in young, you get more of fast ventricular rate episodes. If in elderly, it might be a protective phenomenon by nature, because as age goes on, there is diastolic dysfunction. So when there is diastolic dysfunction, on the top of that, if you have very fast ventricular rates, you will end up in pulmonary edema. So some elderly who reach that in that point, like so suppose they have a very good conduction system even at that age, they are more likely to have fast pulmonary edema episodes with AF. So the basic clinical problems for patients having atrial fibrillation will be one, fast ventricular rate causing acute pulmonary edema, especially sudden episodes of flash pulmonary edema. This will be one differential diagnosis of flash pulmonary edema. In fact, it is a very common cause of flash pulmonary edema in elderly. Renal artery stenosis is MBBS, we used to learn about that. But if you see renal Dopplers, most of the time you find that renal Dopplers will be normal. And you will be wondering why flash pulmonary edema. Even 3 months ago, I had a patient coming from Trivandrum area, and he had run around in multiple hospitals. His only problem was suddenly he'll develop flash pulmonary edema enough that he can't reach the nearest hospital, even nearest hospital. By that time, he'll be in ventilator. There will be multiple episodes, multiple hospitals have evaluated in Trivandrum city, and finally they came. There was not a single episode of AF documented. Even when he came to us, he came with multiple load of papers. Empirically, I just told them that this might be the issue. Other differential diagnosis, already renal artery was evaluated. The first thought is renal artery stenosis. Second will be coronary artery disease. So all angio was done, everything was done. But I finally empirically started amiodarone. I told him, I'm not starting it for the sake of starting. I just wanted you to empirically see. It's a therapeutic trial only. I made him aware, and he went and came back. After 4 months later, he told he used to have every month at least 2 episodes of this. They were fed up of hospitalization. And finally, I had put a Holter. Every Holters were normal. Multiple places I have done Holter. He told that he was normal. So most probably this would be AF. We don't know. We don't have a record, but most probably it will be AF. He told 4 months, not a single episode. He is very well relieved. He was so happy. So I told him other causes are pulmonary vein stenosis, which was excluded by CT. He had taken HRCT for some other purpose. So I went and rechecked the CT to see the pulmonary veins. There were no pulmonary vein stenosis. Pulmonary vein stenosis is another cause of such flash pulmonary edema without any other obvious cause. So it's one of the cause of flash pulmonary edema. That's the essence. Arrhythmia should be thought of whenever there is something sudden. Whenever an elderly coming with a sudden episode, arrhythmia is a prime cause. And recurrent episodic palpitation, sudden abdominal discomfort, because left atrium is a posterior structure. So it is very near the esophagus, and the nervation of left atrium is very close to that esophagus. Esophagus also has some afferent fibers of vagus in that area. So what happens is when there is an atrial arrhythmia, it is a vagus which is stimulated, and so the brain perceives it as an esophageal origin symptom. So that's why many patients with atrial fibrillation actually have sudden abdominal discomfort. They will say the history will be sudden abdominal discomfort, and then suddenly the abdominal discomfort, everything went off without any intervention. So these sort of history very commonly you can get in atrial fibrillation. And as everyone knows, the recurrent cardioembolic CVA is a very common thing. Recurrent unexplained pre-syncope or syncope in a structurally normal heart. Here it's not just AF, it could be ventricular arrhythmias. So it may be malignant ventricular arrhythmias. So we have to evaluate them more seriously. And then excessive fatigue. This is because sudden excessive fatigue. Again, the differentiation that it's an arrhythmia is the sudden nature. Sudden excessive fatigue, that is due to 30% loss of 30% atrial contribution to cardiac output. And more often they are asymptomatic. And I'll come to asymptomatic AF. That there is also something new in that also. And AF diagnosis is nothing great. It's akin to making a diagnosis of jaundice. So we have to differentiate what is the cause of AF in that particular patient before getting into treatment. So first, it may be the valvular heart disease, as Sir told, is quite rare these days. Very difficult to have a valvular origin AF. All the present patients are yesteryear patients who are already known to have AF. You don't get a new AF due to valvular heart disease. Quite uncommon at least. Most common diseases are thyroid, no cause, that's the most common, thyroid diseases and coronary artery diseases. That's what we often get in OP these days. And AF, other group is AF secondary to acute illness. Any patient, for example, a patient having a pneumonia, elderly with a pneumonia, most often they may have an AF. And when you treat pneumonia, AF automatically reverts to normal. And this is basically because Same thing happens in the postoperative. The mechanism of pneumonia causing AF, postoperative state, pericardial effusion, and any inflammatory vasculitis also might cause AF. In fact, now we have a patient who has a Sjögren syndrome in cardiac ICU having an intractable AF. And when the disease activity goes off, it goes off. The reason is interleukins. So interleukins can cause atrial inflammation and may precipitate an AF. This is the same thing which happens in common lobar pneumonia in elderly. They have a higher inflammatory cytokines release which may irritate the atrium. Same thing in Dressler syndrome causing AF, postoperative state causing AF. Here the essence is, it's otherwise called as, the old term is secondary AF. Now that term is not used. So basically the cause is inflammation and around the heart or around the heart. A mediastinal mass can cause AF. So here the rate control is important. You just need to rate control or rarely requires cardioversion if there is hemodynamic compromise. Otherwise just treat the primary disease. Generally the recommendation for post-op AF is to give 2 to 3 months of amiodarone and then stop it. Then nothing is required. Anticoagulation is not recommended because it's only a secondary phenomenon. And clinical problems, as I discussed, it was fast ventricular rate causing acute pulmonary edema. The most this is more common in elderly because as age advances, 2 diseases are there. One is diastolic dysfunction. And on the top of diastolic dysfunction, there is an increased rate. Generally, when there is diastolic dysfunction as age advances, the diastolic time is less. On the top of that, when the rate is more, diastolic time still reduces. So the chance of having pulmonary edema is very fast. So that's why they have flashes as age goes on. So there is more likelihood that 80-year-old has, even if the rates are quite slightly lower, they can have early pulmonary edema. Recurrent syncope due to low cerebral blood flow, that is another thing. And that is due to loss of atrial contribution. They may have sudden syncope, pre-syncope. And CVA, cardioembolism, is most dreaded one because it will disable the person. And basically they are due to atrial or appendage clots. And AF as such, loss of atrial contribution. Generally another common symptom is generalized tiredness. This is a very subtle thing, but it is very common. So you come to know often when you cardio the patient and ask them to come back. After 2 weeks they say that they are generally well. That's the only thing. They say, and they will, once they go into recurrent AF, they will request you to have another, can we do one more cardioversion? So that's only, it's a very subtle symptom, but it's very common. And treatments focused at all aspects of AF, not only the etiology, the clinical problem, and AF per se. So these are the 3 limbs of why we treat AF. And patient workup, usually we do a transthoracic echo to look for the cause of AF, then transesophageal to rule out LA clots, especially in chronic AF. And that too, transesophageal echo is generally performed only if we have an intention to cardiovert to sinus rhythm. Otherwise, generally it's not done. And AF by Holter and EC, that's what I told. These days we have another group of patients who have asymptomatically detected. Patient comes with Apple Watch showing you have irregularity, what to do. Another clinical equivalent is when we routinely check up the pacemakers, you note a lot of AF. Those are mostly asymptomatic. 80% of them we don't do anything. And that is in fact very common. The problem is that when to treat that patient, even that is a content of discussion even in electrophysiology circles. Even last guidelines they changed. One of the area, even as sir told, is a 100-year-old disease, maybe more than that. As soon as it's a disease as soon as when ECG was diagnosed. But even now the last ESC, what they were doing was to change the definitions of AF. The basic definitions of AF is not yet concrete. They are not yet settled. And long duration cardiac monitors have, this is an Apple Watch detected AF. It's a published one. So this is a Medtronic reveal link device. It's an ILR detected AF. And it's an Apple Watch above. It shows atrial fibrillation. The latest one shows atrial fibrillation. The previous models did not show that it is an atrial fibrillation. It just shows irregular pulse. Now it detects, and there is a detection algorithm built into it. And detection algorithm is based on the same things: absence of P waves, irregularity. It shows that it is AF. And implanted device also does the same. They give algorithms detect AF based on the same thing that by which we clinically see the AF. So this is a Medtronic pacemaker detected atrial fibrillation. As you can see, the atrial rates are more and ventricular rates are small and irregular. ESC guidelines for AF management. AF is no longer a single person diagnosis or single person management. There are many people involved, including nowadays patient also, because they have Apple watches, they can always monitor themselves. So patient also contributes to AF management, detection and management. General practitioner, pharmacist. In our hospital, in fact, pharmacist manages anticoagulation very nicely. He calls up the patient. There is an anticoagulation clinic managed by pharmacist himself. They have done a good job. And it was found that the time to therapeutic ratio of oral anticoagulation is extremely low in our own institute. I am sure it is because it is documented. It's not up to the international guidelines. It means we have to go further. We have a lot to improve. Ours was internationally recommended is around 60%. We have still yet to go. Ours is around 45 to 50%. Still it has to go. So time to therapeutic ranges, we have to monitor INR very closely and see in a year how many times the INR is in therapeutic range. So we have to keep INR more in therapeutic range. These days another problem is that in lone AF we don't use much of warfarins. Our hospital mostly use NOAC. So this evaluation is slowly going away. And diagnosis of AF. Regarding this ESC guidelines changes in diagnosis of AF. And in generally, stroke prevention holds of prime importance. Still, stroke prevention is the prime thing that we need to focus on in managing AF. Then etiology of AF needs to be known to how to manage the AF further in the long term also. And preventing fast ventricular rates and acute pulmonary edema episodes, and achieving and maintaining sinus rhythm. Whether we need to achieve and maintain a sinus rhythm is the first question that we have to think of, and that is pretty individualized. It's not the same for the same group of patient. It is different for different patients. Generally, stroke prevention can be either pharmacological. Now, we don't have ticarfarin in India, but it's a new agent which does not have, it's not metabolized to CYP2C9. So, warfarin and ticarfarin, still we have warfarin and coumadins. So, ticarfarin is a new agent. And so there's no need of INR monitoring for ticarfarins. And apixaban, rivaroxaban, dabigatran is well commonly used. It has established itself for non-valvular. What we call as non-valvular is even if the patient has moderate MR, up to moderate MR is non-valvular. More than that, severe MR is valvular. And even if it is degenerative MVP, if it is a severe MR, it is considered as a valvular MR. MS also is same. More than mild to moderate MS, it is considered as valvular. And invasive approaches like appendage device closures are now there. And surgical, in fact, surgeons were the first to manage actually the rhythm control of AF. They did Cox maze. So that was the oldest treatment for rhythm control of AF, non-pharmacological rhythm control of AF. And conservative approach for rate control, as you know, it is beta blockers, calcium channel blockers, and digoxin. Rhythm control, there are many agents. Amiodarone, the problem is these days we are trying to avoid amiodarone. It's a very fine drug, but the problem is that you cannot give it for young patients. Less than 50, it's better to avoid, because if you use more than 200 milligram per day for 10 years continuously, you are sure to get, there's a chance of 68% chance of getting pulmonary fibrosis. That's what the documents say. So another agent which we now has is mexilatin. It is actually a class 2B agent, so which is equivalent to oral lignocaine. So it is very good for ventricular arrhythmias, but now once it is marketed, it has been increasingly used for atrial fibrillation. So it's a very good drug for atrial fibrillation, for resistant atrial fibrillation, where even we now use in ICUs where amiodarone is not effective. Mexilatin can be used for 150 BD. It's a good alternative. It does not have problems like pulmonary fibrosis, tissue deposition like amiodarone. So it's a very good alternative these days for resistant atrial fibrillation, even in structural heart disease. Problems with propafenone and flecainide, dofetilide, etc. are they cannot be used for structurally abnormal hearts. Structurally abnormal means even LVH is structural abnormality electrically. If you take a management of atrial fibrillation, in that context, structural heart disease means even LVH is a structural heart disease. valvular heart disease is a structural heart disease. Coronary artery disease, MI is a structural heart disease because it produces scar. So what is meant by structural heart disease is whether there is a scar or not. So in this context, so propofenone is a very good drug for structurally normal heart. Dofetilide is the best drug for structurally normal heart. We don't have dofetilide, oral dofetilide. We have IV ibutylide. So we use it for structural normal heart cardioversion. It doesn't produce hypotension, unlike amiodarone or any other agent. There is absolutely zero chance of hypotension. So it's a good drug to use in ICU. Flecainide is another drug, but we should be sure that patient is structurally normal heart, no coronary artery disease, no hypertension, and AF patients are mostly hypertensive patients, elderly. So in those groups where there's good LVH, we can't use propofenone, flecainide or dofetilide. Then you are left with mexiletine. An invasive approach is rhythm control. Rhythm control can be with IV. When we start IV amiodarone, you are giving it with two purposes, either rhythm control or rate control. You start amiodarone, it may control the rate, suddenly it may cardiovert. So the risk of a stroke during amiodarone cardioversion is same as for DC. DC only that act of thing is very sudden. It's very dramatic. So, but the chance of stroke is same equal as is for a IV amiodarone. If you start IV amiodarone and go, if that patient cardioverts, the risk of stroke is same as as you do for DC cardioversion. And it's the same when you catheter ablate and cardiovert an AF. So we have to, but the thing is in cath lab we use IV heparin because catheter access is there. So always we heparinize the patient. So that risk is mitigated in a way. So ablation options are 3D mapping and or cryoablation. Or it's either heat energy or cold energy. And in late AF with heart failure, with pacemaker, CRT, etc., as a last option, this is a very last option treatment. AV node ablation, that is just to control the rates. If the rate is causing problem, causing heart failure, for tachymyopathy due to it's a very terminal patients we do that AV node ablation. It's very effective. It actually gives some more life for that patient. These are all very terminal options. And 2020 is the latest guidelines for atrial fibrillation management. What they have stressed is still anticoagulation. So who gets anticoagulation? In structurally normal heart, it is based on CHAD-S2 VAS score. So here more than 2 requires for men and more than 3 for women requires anticoagulation, oral anticoagulation. The only change is that 2019 advocated aspirin for CHAD score 1. Nowadays there is no aspirin for AF management. Either it is you don't anticoagulate or anticoagulate. They say aspirin only increases the risk of bleed in low risk group of patients. It never prevents an AF. So aspirin, it's either that you give aspirin or give anticoagulation or not. One reason why they have took out aspirin was there is a safer choice like Novax now available everywhere. So they have taken off that. Either you can use anticoagulants. Novax are generally less effective than warfarin. It is true that they are less effective, but they are also there is increasing data on safety of Novax when compared to warfarin. That is overwhelmingly coming. So they are emboldened to say that you anticoagulate. Probably the next guideline will bring down the age of anticoagulation if they have proved the safety of Novax. So if there is a 10-year data of, I think now most of the Novax are having 10-year data. Once that comes out, they'll come out with a guideline saying that above 60 or 65 you start anticoagulating. So that's what it is coming to because of overwhelming substantial data coming. So this is probably a start of that. Now they say that they don't have enough proof, that's why. So now they say that you don't anticoagulate if low CHAD score, but at least don't give aspirin. Aspirin has only increased bleeding risk. And another thing what they have stressed is Hasbled score it's a dynamic score. You assess the Hasbled score to assess the safety of anticoagulation. There is bleeding risk. That's what we are assessing here. So multiple points are there like uncontrolled hypertension, but this is a dynamic score. Like once the patient comes, you assess that it's uncontrolled hypertension, Hasbled score is high, so you don't anticoagulate the patient. And then what you need to do is you call up back the patient after 3 or 4 months and reassess the Hasbled score. If the score has come down, you have to consider anticoagulation. So this is a dynamic score, while CHAD-SWASC is single time assessment. And which anticoagulant to give? It's a direct oral anticoagulant is class 1A, so you can always use warfarin, but for non-valvular AF, better that you consider NOACs now. Exceptions are mechanical valve and moderate to severe mitral stenosis. And these are doses. And for reversal, nowadays we need not worry about reversal. Dabigatran has hydroxymab. It is still it's available in even Kochi. We have it since 2017 or 18. We have hydroxymab in Kochi. And rivaroxaban, that we don't have it yet in India, but I think it's there available in Delhi, Antinexad alpha. And Eliquis or apixaban doesn't have a reversal agent as of now. And stroke prevention. And generally stroke prevention is with a non-pharmacological way is nothing new. Surgical occlusion of LA appendage is done by most surgeons, most conventional surgeons. Nowadays surgeons don't do during routine CABG. Otherwise routine CABG also surgeons used to cut off appendages for stroke prevention, because AF was so common. So the most of the guidelines at that times came. This must be in 80s, 90s. But nowadays they preserve appendage. They try to preserve appendage even in MVRs. NB repairs and MVRs, they try to preserve appendage to preserve the mitral apparatus integrity, so that post-op LV dysfunction is low. So they tend to preserve the LA appendage these days. So nowadays other treatments, so it's nothing new. So nowadays there are devices to occlude the LA appendage, like Lariat device, Amulet device. These are different companies only, and basically a catheter is used to deliver a ASD like occluder device into the LA appendage. It is nothing but an ASD occluder modified in shape. One disc is larger, the LA disc is globular and larger, and it has hooks because appendage to prevent slipping back. So there are hooks. Once you put it, it's a reverse hook like this. It's not like this, so it's like this, so it will not come back from appendage. So it's all around this device. So you can see in the second B image some hooks are there. So it's a similar one. It's the procedural difficulty is as easy as ASD device closure. So it just takes 10 minutes. And it is very useful for elderly. That is what we found. Very elderly where anticoagulation is going to be difficult, like 85, 90s AF with embolic stroke. So in such patients where you are afraid to give a good dose of anticoagulation, when we anticoagulate, we have to give even in elderly a very good dose. Otherwise, there is no effect of anticoagulation. So in this age, we are doubtful still what dose to give. NOACs doesn't have a prescribed dose for elderly. They say even if it is elderly, there is one dose. So there is only single dose. So then we think of these devices. And this is what I told. ESC guidelines still are thinking of changing definitions. This one disease where definitions are changing ongoing. Heart rhythm in 2018, there had 6 months, 80% of the articles were AF. The subject of 80% of heart rhythm articles was only AF. And one edition was completely dedicated to AF, despite all this. And they are still debating about guidelines, about definitions, what to define. And asymptomatic AF is where definitions are evolving, because definitions are made only for management. They are focused on management, so that's why it's changing. And this is a very comprehensive, this again from the ESC same guidelines. They say first is to confirm the diagnosis of AF, and then to characterize the AF, and then to further go about risk stratifying the AF, the risk stratifying stroke risk, symptom severity, severity of arrhythmia burden, management of arrhythmia as such, and substrate. So it's very comprehensive. Symptom, the problem oriented approach of AF, then the AF as such management. And catheter ablation. Catheter ablation is quite age old. There has been plus or minus for that. It's one of the method of rhythm control of AF. Particularly the catheter ablation is useful in patients who have acute pulmonedema and fast ventricular rate episodes recurrently. So it is not basically for stroke prevention. So even after catheter ablation, what is to remember is stroke prevention continues. And basically, what is done is pulmonary veins are isolated electrically from the left atrium, main body of left atrium. There are different strategies of ablation where you isolate only the pulmonary veins and then you tackle the body. Again, that depends on what caused the AF. So here we find that it's not just 80% of the lone AF are due to pulmonary vein tachycardias. They are not truly diseases from the atrium, they are from pulmonary veins. So that is why pulmonary vein isolation is done as a first procedure in all cases of atrial fibrillation, whether it is RF, cryo, etc. Other methods, whether to go about other foci in atrium depends on the basic disease. In India, there are, Chitra had actually a series of rheumatic heart disease atrial AF ablation, where they found that most of the foci are in the posterior left atrium, as Ernakulam patch is well known. So most of the foci are in the atrium, but they found that they are focal arrhythmias. They are not just micro reentries. They have many focal atrial tachycardias where they could ablate. So we don't have much rheumatic disease, so experience in these days, that's why. So persistent AF ablation, persistent AF, more extensive ablation is done. So you may have to do multiple approaches like box isolation, touching ring, single ring, debulking. These are all methods of ablation to tackle most of what they say is atrial fibrillation when there are multiple mini rotors in atrium. They are small galaxy like highly pulse rotations. Rotating rotors, they are called rotors. So they do even rotor ablations. Cryoablation is a one-shot approach. Here it is easy because you are ablating a wider area. Here it was a point by point ablation. We have to do each point. So a line is created by joining different points. Here, and these are heat. The difference is heat is slightly more permanent. So once you ablate a point, that point is ablated. So that point usually doesn't conduct. Here there is another in between area. So cryo has some safety because at minus 30 we cool the balloon to minus 30 and the wider area is ablated to minus 30. Suppose you have a complication, you can stop the cooling and it re-thaws back. It thaws back to the room temperature and usually we get the conduction back. But if you want to ablate more permanently, you just continue the ablation. There is a mode of continuing the ablation to minus 55. Minus 55, minus 60 or minus 70 you go. Minus 70 is maximum for nitric oxide. So it's just inside the balloon there is a nitric oxide gas is circulating and that will immediately cool to minus, usually tissue temperature reaches about minus 55 to minus 60. The temporary one is minus 30 to minus 40 tissue temperature. And nitrous oxide is minus 40 you achieve temporary ablation and for minus 70 you get permanent ablation. So at that temperature tissue is permanently it will stop, it will denature the protein and produce coagulum inside the cell and that's how it ablates. So the essence is that it's a balloon, either it's a point catheter, it's usually a balloon and pulmonary vein isolation takes only about 20 minutes. And you effectively ablate a very wide area in a very short period of time. One problem with 3D is that the patient has to lie down for a long time because we have to make each point. So the whole atrium we have to address. So it's a 6 hour or 7 hour procedure if you do a very detailed proper ablation. Otherwise you won't have effect. While in cryo, the 6-7 hour procedure gets converted to maximum. It's a 3 minute for each vein. So 3 into 4, 12 minutes for whole ablative procedure once the catheter is in. The procedure is simpler, it's more comfortable for the patient. That's the advantage of these two therapies. In general, this is the AF guideline management. It's in the ESC guideline. Presently, if you take broadly, it's an acute rate and rhythm control and manage precipitating factors. Very common precipitating factor we often get is obstructive sleep apnea. Unaddressed obstructive sleep apnea, whatever you do with the AF is not going to get controlled. That is very commonly found. It's just like uncontrolled hypertension. AF also will not get controlled whatever you do. I had a patient whom, an obese guy, AF was ablated. We thought it was a lone AF, there was no obvious factors. Finally, he was an obese person. So then finally, after 2 years, there was recurrence of AF. So he was questioning us why there was a recurrence. So finally, it was a obstructive sleep apnea. So then assess stroke risk, assess heart rate and assess symptoms. So it's a more comprehensive approach these days. AF, as I told, is just like saying jaundice. what is a person's cause of AF, we need to know before going to AF. In conclusion, AF is a disease of aging and incidence increase with age. Idiopathic AF still commonest at present. It's the most common cause of cryptogenic stroke in elderly now in India as per an NIMHANS study, observed registry. And stroke prevention is of primary importance. Non-medical options for stroke prevention is now available, like Atrial Appendage Device Closures, lariat devices. They are a good option in patients with high bleeding risk and especially in very elderly above 85 years of age. In young patients, catheter ablation than long-term medications needs to be first considered. There's a recent JACC article paper which actually FDA has approved cryoablation as a first-term therapy for paroxysmal atrial fibrillation, first time detected AF, as a first time therapy even without starting drugs. That's a recent one. And cryoablation achieves more wider area of ablation in a short period of time and is effective elderly in early phase of natural history of idiopathic AF. We need not, because AF begets AF. So that is still holding true. That is because as age goes on, scars inside the atrium, these rotors will produce more scars as altered electricity. So it is very true that even pathophysiologically and electrophysiologically AF begets AF. That still holds true. So when we treat AF, if we want a rhythm control, we need to do it earlier in the natural history rather than going late. Very late AF, better leave them, and once the atrium is dilated, we might not get back a good result of atrial fibrillation, ablation and all. Okay, thank you.
Thank you, Dr. Praveen, for that excellent discourse on atrial fibrillation to A to Z. That, when we first learned about atrial fibrillation, like I said, and now there's a sea change in our approach to it, though the basic condition remains the same. Thank you very much for the talk. We'll have 5 minutes for discussion, but there is one more topic. Anybody has any questions? Yes, doctor. Please use the mic.
When we do the ablation, we know the left atrium is very, very thin, and you are producing a lot of heat when you radioablate a patient, radiofrequency ablation of a patient. Won't it produce a lot of problems, like maybe a perforation, maybe a thrombus formation, and it's close to esophagus, can produce esophageal stricture?
Yeah. These are the problems which was thought of with atrial fibrillation ablation. Stricture, even there are reports of tracheoesophageal left atrial to esophageal fistula, which is the thing which people fear about most, because suddenly patient will have a hemolysis after 1 week. It's not immediate, because the effect of ablation is it's over weeks and months. So there were initial reports of LA esophageal fistula causing even mortality. So that's all in the initial part of this ablation when this was evolving. These days, I think it doesn't happen. One, the energy of ablation is very controlled, and as you told, a left atrium is very thin, 3 to 4 millimeters a normal left atrial thickness, muscle thickness. So in RF ablation, one thing is when we ablate it, we can control the depth of ablation in an indirect way. These catheters we will not cool, but if we do a more cooling, there will be a deeper ablation. So here it's only a surface ablation, just inside the surface. So it has been found by even autopsy studies that ablation lesions do not go beyond a certain point, like 2 millimeter. So that's how it is. The rate of cooling is adjusted to that, and it is well established nowadays over last maybe 30-40 years. So the amount of cooling, the rate of cooling, and what energy is delivered to the catheter, RF energy. So these decides. It's not that one thing in AF ablation that we fear most is, and in fact that also complication came as a treatment. Initially when we used to ablate AF, we used to get asystole, sudden asystole, and that was something which we feared. Left atrium, especially when we ablate the left superior pulmonary vein, that area, left atrial area, left sided veins, we used to have asystole. Patient suddenly goes into asystole. But later it was found that if you continue ablation in that area, then the recurrence of AF is very small. And if you ablate in asystole, you can find that the sinus rhythm comes back. So that is because when we are ablating, we are giving heat to the ganglion just posterior to the left atrium. So that is now coming as a ganglion ablation. It's a method of AF ablation strategy. So nowadays, the only two complications we fear in AF ablation, in RF ablation, is phrenic nerve injury. Phrenic nerve injury is we pace the diaphragm when we do right-sided veins. So and as we ablate, we can pace the phrenic nerve. That is usually done. So in that way we can avoid. As and when the diaphragmatic, and we know on fluoro we know the diaphragmatic position. So as the amplitude of diaphragmatic contraction comes down, we stop ablation. So that's how it is done. So there are ways to counter these complications these days. Generally, I don't think the last 10-20 years we have heard of esophageal fistula or a phrenic nerve injury, but it can happen.
So one last question, if I may. We get a lot of stroke patients where we don't know the cause at all. So it could be just a paroxysmal atrial fibrillation.
Yeah.
So do you suggest all these patients we should do Holter monitoring?
In nowadays, as per NIMHANS data, I think it came in 2014 or so. There's a large series, population series. I think that's the only one which is there in India. And in that it was told that in elderly above 65 years old, the most common cause of stroke is now AF. Not even the hypertensive heart disease. They have found that is the most common cause. So probably it's a neurologist who should be screening for AF these days. That is the most common cause. For all strokes, I am not very sure. It has not come in guidelines. I am not very sure of the stroke guidelines. It has not come like that. Presently, what neurologists do is, suppose they have no other cause to find out, non-hypertensive, no other obvious risk factors. Hypertension requires few number of years to have atherosclerotic changes. So if they think that that's not the cause, they advise a Holter. Even they advise a Holter. And that's why AF pickup rate is also higher these days. Incidence has gone up.
If you pick up AF, then we have to put on anticoagulants.
Anticoagulation recommendation presently only for a documented AF. If you don't have a documented AF causing a stroke, there is no recommendation for anticoagulation as of now. Blanket anticoagulation is not yet recommended in any of the guidelines.
You were talking about this thing, this cardioversion while treating AF. You are meaning cardioversion by drugs or with DC or
both. Cardioversion just mean to convert to sinus rhythm. It is better to give a drug trial of cardioversion like ibuprofen or amiodarone, and if not, you can go with DC cardioversion.
Okay. If that fails only, the drug fails only, you go for
that is common because DC cardioversion, elective DC cardioversion for AF, we have to get a consent for the patient. It's a procedure. So if you can convert with drug, it is good, but the stroke risk remains the same. So when we cardiovert a person, you need to tell in an elective cardioversion, you need to tell the risk of stroke to the bystanders before cardioverting, even if you are giving IV amiodarone.
Thank you.
That's only.
Any further questions? Or we can end this session. Thank you very much, Dr. Praveen Sreekumar, for sharing your wealth of experience and your knowledge with us. I'm sure we all go back with more insights into the topic of this common but difficult topic. Thank you very much. Also thank the organizers for giving me this opportunity to chair this session. Thank you.
May I request our Chairperson, Dr. Sujith sir, to present the memento of our appreciation to Dr. Praveen Sreekumar. request Dr. Rajendran sir to present the memento to Dr. Sujith sir.